Welcome to April Fool's Day 2026. This year, the theme is Let's Talk About Falls. Staying safe starts with a chat. I would like to acknowledge the traditional owners of the land on where we meet today and pay our respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal or Torres Strait Islander people joining us here today. The Clinical Excellence Commission recognises and values consumers, patients, carers, loved ones and staff as partners in healthcare. The voice of people with lived experience is powerful and their contribution is vital to the work of continuously improving safety and quality in our health system. April Fool's Day 2026 theme is Let's Talk About Falls. Staying safe starts with a chat. So this is really reminding staff to look out for these subtle changes in older people. And when we do highlight these changes, that we then put in place some actions to reduce the risk of these changes causing the patient to fall in hospital. So some of the changes to look out for are changes in cognition, so that could be alertness, agitation or confusion, any medication changes, any changes in their toileting, they may have more urgency to go to the toilet. Have a look at their walking speed. Has it become slower or unsteady during their hospital stay? Are they holding on to the furniture for support? Are they telling you they're a bit more dizzy or lightheaded? Have they had some vision changes or just some general changes in their care needs? So if you do notice these changes, we encourage you to investigate them, escalate them to the wider multidisciplinary team and have a chat to the patient, family and carer. Are these changes new? Is this something that's been developing over time? It's really an opportunity to get to know your patient. One thing I'd really like you to get out of today's presentation is to really understand that falls just don't happen. There are contributing factors to falls when they happen in hospital. It may be that reduced strength and mobility if they've been lying in bed all weekend, have their muscles in their legs become weaker, and does that affect their mobility? Do they have impaired balance or gait changes? Have they developed a confusion or a new delirium? Are they dizzy? Is it from their postural hypertension? Could their medications be affecting them? Or is it really just their acute illness? They're very unwell in hospital in an unfamiliar environment. We know from research that patients consider themselves safe in hospital and they don't think that they're at risk of a fall. But we know that they're in an unfamiliar environment, they're unwell. Therefore, the patient won't know what their fall's risk factors are and how they'll be managed in hospital unless you discuss it with them and their family or carers. Falls risk is dynamic and can change throughout a person's hospital stay. Hospital can change patients. Leg strength declines rapidly with bed rest and can affect their mobility. Acute illness affects energy levels, cognition and balance, and medications can be added, ceased, adjusted. And the amount that the patient eats and drinks throughout the day will fluctuate, and they may need a reminder to stay hydrated. This is your reminder that a patient may be independent on admission, but may not be independent on day 3. Falls risk is not static and it must be reassessed, not assumed throughout their hospital stay. Informing a patient that they're at risk of falling isn't a prevention strategy. And risk labelling during handover that this patient is a falls risk isn't a management strategy. Risk awareness alone does not change behaviour, it does not reduce delirium, and it doesn't prevent harm. Saying or documenting that a patient is a high falls risk is not a diagnosis. As clinicians, we must identify and communicate specific patient risk factors, such as postural hypertension, delirium, they're on sedating medications, reduce lower limb strength. new mobility age, and they may have developed some deconditioning after bed rest. When communicating with a patient, instead of saying you're at risk of falling, you could try saying, you've been feeling dizzy when you stand, so please ring the call bell before getting up. This is obviously only an example that would work with cognitively intact patients. During bedside handover, it's really important to hand over risk factors, not just falls risk. When an incoming nurse is coming in for the next shift, saying a patient is a falls risk really is quite meaningless for them. They need to understand what's driving that risk, what needs to be monitored, and what interventions are in place. So here's some examples of what you could say. If a patient has postural hypertension, you could say that they need some more assistance to mobilise, or they need to ring the call bell before they get up out of bed so that you can assist to mobilise them. You could say this patient, if they've got a new delirium, that they've developed a delirium overnight and they require some constant supervision. If a patient has deconditioned, reminding the nurse that they now require a one-person assist and their walking aid to help them mobilise throughout the day, or just to note that they're on some new sedating medication and to monitor alertness before mobilising. Handing over like this really clarifies what the incoming nurse is managing. It helps them make their care plan explicit, and it reinforces the risk factors with the patient and the family, and it really promotes a shared accountability at the bedside. Bedside handover isn't just a ritual, it really is an opportunity for a safety intervention. Intentional rounding is another opportunity throughout the day where you're able to put the care plan into place. It's not just popping your head in and asking, are they okay? It really is a structured safety intervention. As we know, most older people don't want to be a burden to staff. So instead of saying, do you want to go to the toilet? You could say, I've got a couple of minutes. Why don't I help you mobilise to the toilet now? Have a look at how much water they've drunk, or if they've eaten their meal. What's their urinary output? What's the quantity, colour? When was the last time they opened their bowels? Is that normal for them? Try to understand if they're in any pain or discomfort. Now, patients with a dementia diagnosis may not be able to communicate that they are in pain. So look for signs that they're in pain, or changes in behaviour, aggression, restlessness may be signs that a patient with dementia is in pain. Be aware of any changes to cognition, agitation, or restlessness that have developed since the last time that you were in the room. Intentional rounding really is an opportunity to detect deterioration early, anticipate patients' needs prior to mobilising, and deliver the care plan, not just document it. Intentional rounding really is proactive care. This slide with the building blocks for a safe ward really highlights the opportunities during the day that staff have to communicate patient risk factors and how they're going to be managed in hospital. We've talked about bedside clinical handover, but other opportunities are safety huddles. These happen every shift, every day, to understand which patient or patients are at greater risk today. Multidisciplinary team rounds, these can happen 1 to 2 times a week, and it's when the multidisciplinary team talks to the patient to ensure that they've got a common goal. Intentional rounding, we've already talked about that as well. It ensures that patient care needs are met. And post-incident huddles, they're an opportunity to understand what happened and then to learn and improve for next time. I now want to talk about a patient story. We've got Mrs. Thompson, aged 84, admitted with a fall. She was independent on day 1. On day 3, she was walking a bit slower, holding on to furniture. She appeared mildly confused and complained of being lightheaded. She had another minor unwitnessed fall overnight. The initial reaction from staff is she's just elderly and unsteady. There's nothing more we can do. But the clinical reality is that she has developed a delirium secondary to infection, and her hypertensive dose was unchanged despite reduced intake. So if we just focused on the fall, did she hit her head? Was there a fracture? Was it a mechanical fall? There was no fracture, no head injury. Observations are mostly within range, maybe just a slightly raised respiratory rate. Nothing dramatic. But her daughter says something important. Mum just hasn't been herself. She didn't answer my call the other day. She sounded breathless the last few days before coming into hospital, and she's been tired all week. A chest x-ray later shows that she had right lower lobe pneumonia. Mrs. Thompson didn't present with a cough. She didn't complain of chest pain, and she didn't spike a fever. Her first clinical sign of deterioration was the fall. In adults, illness often presents atypically. Instead of a fever, productive cough, shortness of breath, we see a fall, a new acute confusion, functional decline, and reduced mobility. The fall wasn't the accident, it was a red flag. When Mrs. Thompson's pneumonia was treated early, she avoided ICU admission, she avoided prolonged delirium, and she returned home. If we had labelled it simply as a mechanical fall, we would have missed the evolving infection. That last patient story really demonstrated that families and carers can help us detect change, personalise care, and hopefully prevent avoidable falls. It's really important to have the conversation with patients, families and carers early. Is their mobility different to normal? Is their cognition different from usual? Do you have any concerns? And what are their routines or strategies that they like at home? Do they like to shower every day? Do they like to have a bottle of water always available for them to drink? But remember, for patients with dementia, it's really important to identify and understand their usual routines and any triggers to behaviour. Confirming, calming and de-escalating strategies with families is really important, and remember to document these in either the top 5 or the sunflower tools. So here's something to consider. Do we need to treat falls as incidents or as indicators of unmet clinical needs? Every fall should trigger a review of acute deterioration, medication review, mobility and functional reassessment, and delirium screening. If we normalise falls as part of ageing, we miss opportunities to prevent harm. We should treat the fall as a clinical red flag. Let me introduce you to a patient, Mr. Jones. He was previously independent. He's had a fall. While assisting him back to the chair, you notice that he's become confused. You do a 4AT and he has developed a delirium. You escalate for a medical review and it's confirmed that he has developed a urinary tract infection. The fall wasn't the primary problem. It was the first clinical sign that something else was going on. In older adults, deterioration rarely announces itself loudly. It whispers. It might look like a fall, it might look like a new confusion or reduced mobility, not eating enough, or just feeling off and unwell. For April Fool's Day this year, we've pulled together a number of resources. We have some posters that are for clinicians and for patients. We have some MS Teams backgrounds that you can add to your computers if you would like to, and also some email signatures that you can add to the end of your email. If you scan the QR code, that will take you straight to the April Fool's Day resources. They're held on the New South Wales Falls Prevention and Healthy Ageing Network website. If you have an interest in falls prevention, I really encourage you to join the network. It's free to join and you'll receive regular newsletters, you'll receive research updates, but you also receive notification of events that we run. Our next event that we're running is the annual Falls Prevention and Healthy Ageing Network Forum on the 1st of May, which is being held at the Wesley Centre in Sydney. We also run rural forums throughout the year, and there's exercise to prevent falls in older people workshops. So look, if you have an interest, please join the network. We'd love to see you at one of our events. Thank you.